Good afternoon to one and all. I welcome you all on today's webinar session on safety of mother in pregnancy on behalf of Varanasi Society of Obstetrics and Gynecology. As we all know, to get the healthy outcome at the end of pregnancy, we should provide healthy and safe environment to a pregnant woman, give her good antenatal care, identify high-risk pregnancy and manage them on time. Today, we are here to know more about RH immunization and domestic violence during pregnancy from renowned and acknowledged speakers. Now, I would like to welcome President of Varanasi or Society of Obstetrics and Gynecology, Dr. Uma Pandey ma'am. Ma'am is professor in Department of Obstetrics and Gynecology. IMS BHU Varanasi. She is examiner for MRCOG examinations. She is currently president of VOX Varanasi. She is ICOG Governing Council member 2018-2020. She has many international and national publications, lectures at Foxy conferences and also internationally. She has her heat stable carbitocin versus oxytocin to prevent hemorrhage after vaginal birth, incorporated in WHO recommendations, publications in New England Journal of Medicine 2018. Ma'am, over to you, ma'am. Uma Pandey, ma'am, for presidential address.
Thank you, Vanita. Everybody can hear me? Hear me? Everybody can hear me? Yes or no?
Yes, ma'am.
All right, great. Right. So I would like to welcome, that is my first job, everybody, guest of honors, and that is Professor Ashok Kumar. I can't see him though. And I would also like to welcome Madam Asha Bakshi. I can see Ashok sir. Ashok sir, welcome. Then I would like to welcome our chairpersons, our teachers, Mata ma'am, Nisha ma'am, and also Dr. Shikha Sachan ji and Dr. Mamta ji. And our speakers, and that is Dr. Ritu Khanna, very well known to us, and Dr. Stephen Lindo. We know him because he has been with us once before. And our colleagues, our seniors, our friends, and our dear residents as well. I hope they have joined. Then I would like to welcome our moderator for the day. That is Rita. First moderator is Dr. Divya Divedi, and also would like to welcome those I have forgotten because I may forget something. So today you might wonder why the topic, the webinar's name is safety of the mother. The reason being safety of the mother comes from two aspects. One is that obviously rhesus immunization, if you cover the mother well, or if you investigate the mother well during the antenatal period, then the outcome of the baby, the neonate, and the mother, everything is very good. And the second topic is domestic violence. Then I think Vanita asked me why domestic violence. Domestic violence is not very well researched in India. But when the lockdown happened in India, there were many papers and many news channels which reported domestic violence. And since then, domestic violence had become a hot topic in our country. And therefore, I want to as well again and get some insight into it and may further manage. We have heard Dr. Ritu Khanna on many occasions, and she does very well. She does justice to her topic. And then we will be hearing Mr. Lindo after that. So looking forward to the whole program, and thank you for joining. Okay, back to you, Anita, now.
Yes, ma'am.
Yeah,
I will invite Uma Pandey ma'am to welcome our guest of honor for today, Dr. Ashok Kumar and Dr. Asha Anil Bakshi ma'am.
Yes. I would like to welcome Dr. Ashok Kumar sir. He is Director Professor, Department of Obstetrics and Gynecology from Atal Bihari Vajpayee Institute of Medical Sciences, and Dr. Ram Manohar Lohia. I think that's a new name of MAMC. I don't know. New Delhi. And congratulations, sir, on being elected as a ICOG secretary. for the period of 2021 to 2022. And I'm sorry that I won't be able to work with you in ICOG.
No, but it is not mandatory that you should be the governing council member, then only you will work. Otherwise also you will be the part of the ICOG.
Okay, sir, thank you. And our second guest of honor is Dr. Asha Bakshi. She is MS, FRCOG, FICOG. She is director of Disha Fertility and Surgical Center, Indore, and lead consultant at Dr. Asha Bakshi Fertility Center in association with Motherhood Hospital, Indore. And I'm proudly announcing that Indore is the cleanest city of India. Joint Secretary ISR 2021, Founder Chairperson MPIAGE and MPISR, Chairperson Foxy Infertility 2017 to 19. To her credit goes the first ICSI, TISA, ICSI and Micro TISA, ICSI babies of MP, Madhya Pradesh. Recipient of Dr. Kumud Tamaskar Award, Foxy 2008. Best paper in Foxy Journal 2011 to 12. Runs Foxy recognized infertility and endoscopy courses and certificate courses for ICOG in infertility and endoscopy. She has organized many conferences like Star Endogyne 2019, ICCON 2017, ISR 2016, Joint Organizing Secretary of IFFS 2016. Organizing Chairperson of AICOG 2021, which will be held in Indore. When it will be held, we don't know. Coming up. Hopefully we get some date and we'll be all excited to come to Indore. And contesting for the post of Vice President, and we wish her, all of us, all Banarsis wish her very best.
Thank you.
And I again welcome all of you. And Vanita, mic back to you.
Today we have renowned and acknowledged chairpersons with us today for chairing today's scientific session. Dr. Manjari Mata ma'am, Dr. Nisha Rani Agarwal ma'am, Dr. Mamta Singh ma'am, and Dr. Sikha Sachan ma'am. Professor Manjari Mata ma'am is the ex-HOD of Obstetrics and Gynec Department of IMS BHU Varanasi. She is ex-president of VOX, Varanasi branch of Foxy. She has National Scholarship by Government of India in high school, rank holder of MBBS final profession, examination in IMS BHU. She received Prabhavati Malhotra Oration by UPCOG 2013, Dr. Basu Malik Oration by VOX 2015, Vijay Shri Award in 2015, and Shiksha Ratna Puraskar in 2010. She is Fellow India College of Obstetrics and Gynecology and Foundation of Integrated Medicine. She has 100 national publications and international publications. She trained in UK and US on various aspects of obs and gynae. Trained medical officers in family planning, and she has a special interest in emergency obstetric care, cancer and HIV prevention. Our next chairperson is Dr. Nisha Rani Agarwal ma'am. Ma'am is currently professor and head of the Department of Obstetrics and Gynecology, IMS BHU. She has total clinical and administrative experience of 36 years. Ma'am has Arthur Ashe Fellowship, New York, USA. Ma'am has a special interest in labor analgesia, HIV in pregnancy. Ma'am has various publications measuring about 69 in various national and international journals. Next chairperson is Dr. Mamta Singh ma'am. Ma'am is Associate Professor in Department of Obstetrics and Gynecology, IMS BHU. She is presently Scientific Secretary of VOX. She worked as Treasurer of VOX in 2018-19 and Joint Secretary of VOX in 2019-20. Our next chairperson is Dr. Shikha Sachan ma'am. Ma'am is currently working as Associate Professor in Department of Obstetrics and Gynecology, IMS BHU. Now, I would like to invite Manjari Mata ma'am to introduce Dr. Ritu Khanna ma'am. She will be talking today on RH ISO immunization. Over to you, Mata ma'am. Manjari Mata ma'am. Ma'am? Manjari ma'am?
Please ask Nisha madam. Let the proceedings go. Don't wait.
Yes.
Nisha ma'am.
Nisha ma'am.
Introduce Dr.
Hello.
Ma'am, are you there?
Hello. I'm here, Dr. Mata here.
Okay.
It's my pleasure to introduce Ritu Khanna. She is shining star of Varanasi. Her biodata is elaborate. What to say? She is MBBS, MS Obs and Gynae Gold Medalist, Director of Khanna Medical Center Fertility Clinic, fertility specialist and endoscopic surgeon, received her IVF ICSI training in various centers of India and also in Belgium. Organizational position she held. She's chairperson elect for Seafood and Drug Medico Surgical Equipment Committee, Secretary Society of Fetal Medicine Varanasi chapter, Vice Chairperson Women's Director Wing IMA Banaras branch, Vice President VOGS 2019-20, Secretary VOGS 2018-19, Joint Treasurer Indian Fertility Society 2018-20, Co-Convener SIG IV IFS Ultrasound 2018-20, Scientific Secretary IMS Varanasi Chapter 2020-21, Organizing Secretary UPCOG 2019, Organizing Secretary Fertivision 2016. She worked on exclusive single embryo transfer. Awards she received are Best Chapter Award as Secretary IFS UP Chapter at Fertivision 2015, IFS Best Executive Award 2016, Dr. B.C. Roy Memorial Award 2018 for outstanding contribution in the field of gynae. Many papers on male and female infertility, published her first Indian study on the role of COQ in male infertility, presented many papers in ISAR, IFS and AICOG. Laparoscopic and astroscopic fertility enhancing surgeon, USG color Doppler, 3D, 4D ultrasound, IVF ICSI center is recognized by Foxy for IUI training. I can't read any further.
Thank you. Thank
so
you
she
so
is
much.
going to talk on rhesus isoimmunization. Ritu, you are welcome to deliver your talk.
Yeah. Thank you so much, madam, for the really kind words. Respected guest of honor, Dr. Ashok Kumar sir and Dr. Asha Bakshi ma'am, President Dr. Umak Pandey and Dr. Madlika Singh, and our respected chairpersons today. It's a proud privilege to be on this platform here among such an august gathering to address and to be here with you. And I would be speaking on RH isoimmunization. There are more than 35 blood groups which are being recognized, and they are ABO-RH, KEL, Duffy, and large number of names. And most of these antigens have been found to be associated with a hemolytic disease. But ABO and RH account for around 98%. The two group systems, ABO and RH, with the respective antigens. And just to revise, each of these ABO have their antibodies too. Now, the fetus inherits one gene from each parent which are present on the chromosome 9, and thereby by acquiring this, it gets into the various blood groups of ABO system. 25% of them are ABO incompatibility, but yet, because of these antibodies, only 5% have a chance of developing the hemolytic disease. The RH antigens which were discovered in 1937, and it's a most important blood group system after ABO, consisting of around 50 defined blood group antigens, among which 5 are the most important. The genotype is determined by inheriting at least 3 pairs from each parent, closely linked allelic genes on the chromosome 1. And they are the small and the bigger C, D, E, E, and the small d has no antigenic expression. There are only 5 effective antigens. The D is a big brother. It's a most immunogenic antigen and has got 16 epitopes, structurally similar but with different antigenicity. And if you go into the genotypes, these are almost all the frequent genotypes, and we have the most which are immunogenic are shown over here. So, if it's a D positive person, that means the husband is RH positive. He could be either heterozygous or homozygous, and depending upon this, would be, if he's a homozygous, then 100% would be RH positive. If he's heterozygous, around 50% would be RH positive. And out of all, at least 50% are heterozygous. If there is an Rh incompatible couple where the father's genotype is not known, yet there is a 67.5% chance. Coming to the incidence, it's globally the basic population of Spain which has got the highest, and coming to the white and the Americans and the Africans and the Asians have just 2% or less. It's just Rh is a protein. It's found in the red blood cells, and the person who's having does not have this factor is an Rh negative, and the Rh negative mother exposed to Rh red cells from the fetus would produce antibodies, and this is called as an isoimmunization or an alloimmunization, which means there is an immune response in an individual of one species to an antigen from a different individual, but this individual is from the same species. So it's an iso or allo. Once it's your one's own antigen, it's an auto, and antigen from a different species is a xeno. So now these antibodies could cross the fetus, cross the placenta, and there form complexes over there. And these affected RBCs are going to be destroyed now by the reticuloendothelial system of the fetus. So Rh negative mother, there's a fetal hemorrhage, the RBCs, the Rh positive into the maternal circulation, thereby the antibodies. But how and how much does it occur? It's around 10% only during pregnancy, and look at it, the most of it occurs during the delivery. There could be a sensitizing event. What could it be? In the antepartum, the various miscarriages, ectopic, any procedures which you are going through, amniocentesis, CVS, or doing a cephalic conversion, doing a fetal blood sampling, or doing an intrauterine blood transfusion, or even a blunt trauma could cause a fetal-maternal hemorrhage. The forceps delivery, the cesareans, and of course multiple pregnancy, hydrops, if there's a placental abruptio placentae, and if you're manually removing the placenta, or any history of blood transfusion could sensitize to Rh isoimmunization. The fetal RBCs have been found in the maternal blood in all the 3 trimesters, even without an apparent predisposing factor. And if we go into the trimesters, we see here, the first trimester has the least, it's 5%, and then goes to 47%, and then at the time of delivery, it's 75%. And chances of getting a primary sensitization in first is just 1 to 2%. If there is an ABO incompatibility, it will, of course, decrease the isoimmunization. Now, the initial response is IgM antibodies are formed, and iris sensitization is low levels of these antibodies. They're confined to the circulation. They're not going to cross the placenta. They're high molecular weight, so the first baby is not affected by these IgM antibodies. It takes around 6 weeks to 6 months, and then comes the IgG antibodies. It's going to just cross the placenta, just go to the fetal positive and destroy them. And the firstborn infants are not therefore affected, but the short exposure of first exposure of mother is insufficient, therefore, to produce these amounts of these IgG antibodies. But subsequently, with the Rh positive fetus, there's an amnestic IgG response going to cross the placenta and thereby really affecting the fetus. And we need to see that as little as 0.1 ml would even be necessary to cause this Rh incompatibility. But studies have been there and showing that 30% of people may be such. They are non-responders. They never develop Rh incompatibility, even when they are challenged with large volumes of Rh positive. So if there is a 0.1 fetal-maternal, then the 3% sensitization, and if it's more than 5, it's a 65% of sensitization there. So in all pregnancies, small amounts of the maternal blood enters the fetal circulation. And there's something which is called as a grandmother effect or the theory. It's the PCR has been used to identify the maternal D positive DNA in the peripheral blood from the preterm and the full-term D negative newborns, and possible for a D negative female fetus to expose to the maternal positive red cells to develop the sensitization. Now, when this person is going into the adulthood, she may produce antibodies even before or in early first pregnancy. So this is called the grandmother effect, because the fetus in the current pregnancy is jeopardized by the maternal antibodies that were invoked. So what happened was that the fetus immune system developed a permanent template at that time for the Rh positive antigen. And when the fetus became a mother herself, exposed to a load of antigen from her fetus, the immune memory is now recalled. There's a secondary immune response which occurs. So the IgG enters from the fetal circulation via the placenta. There's destruction of the RBCs and thereby causing severe anemia, hematocrit. When it goes less than 30%, it's anemia, severe anemia. Now the same is converted to bilirubin and therefore a fetal hyperbilirubinemia. And then both are neurotoxic but effectively cleared by the placenta and metabolized by the mother. Now, because of this, there is more demand on the extramedullary sites, and they have to produce more RBCs. So there is immature elatoblasts which have come. The heart failure eventually results. There's ascites, there's edema, there's pericardial effusion, erythroblastosis fetalis, and after that, the hemocrit may still fall down. If it goes below 15, it's a hydrofetalis, and it's very, very risky. There may be a fetal death shortly before or after the birth. So all these events could occur even with small amount of the leakage. So after birth, antigen antibody reactions on the RBG surfaces, the hemolysis, the anemia, the jaundice, connectors, and even may lead to the fetal death. Yes, the hemolytic disease may present either as a mild hemolysis, which could be tolerated. There could be mild anemia, jaundice, just at birth, it resolves without even any treatment. Or of course, there may be increasing bilirubin level cleared by the placenta. After birth, it's not cleared because the liver is immature and therefore hyperbilirubinemia, the connectors, moderate anemia, and the postnatal will need treatment. If it's a severe fetal anemia, there would be hepatosplenomegaly, erythroblasts, and of course, the consequences are very bad, leading to a cardiac failure, high drop, stillbirth, and even a neonatal death. So what is our objective today? We want to prevent the RH isoimmunization in the RH negative unsensitized women. We want to also early detect and treat the fetal anemia in those women who have been sensitized. So sensitization we would do by the indirect Coombs test. Now, if she comes to us with the first pregnancy, we do it at the first booking and then repeat it around 28 weeks. If she's coming with a subsequent pregnancy, the previous pregnancy history is taken, she had no or mild hemolytic, it's at the first booking and then every 4 to 6 weeks. If she had a very severe hemolytic disease in the previous pregnancy, the titers even may not be required. We just start for testing the fetal anemia beginning from 16 to 18 weeks. So now if she's a non-sensitized pregnant woman, we've done the blood group of the husband, it's positive, it's negative, it's okay, there's no problem. If it's positive, we have to find out is a homozygous or a heterozygous and then go with the antibody titer 2. So the aim is now that you have, if she is a indirect Coombs test negative, so we could just give her anti-T. So what we want to do is we want to minimize, there should be no chances of any fetal maternal hemorrhage, and we try to prevent it and also prevent the alloimmunization and therefore giving her the anti-T at this point of time. So it could be repeated again at 28 weeks and 34 weeks. So we've done a prophylactic anti-D has been given. And if there has been any event in this point of time, giving a sensitizing event within 72 hours, again giving it to her. If she's less than 12 weeks, yes, 50 micrograms, and more than 12 weeks, 300 micrograms, and the dose adjusted according to the Kleher-Betke test. Yes. So this Kleher-Betke test is, of course, an acid dilution test, and the fetal hemoglobin is more resistant to the acid, and therefore they appear as bright pink fetal cells, and the maternal appear as ghost cells. And by this, you can determine the fetal volume, pick it up, see how much is it, and how much anti-D now you need to give her. 100 microgram would neutralize 4 ml. So when the mother is delivering, again, we have an entity, we examine the neonate for the antibodies, we do a direct Coombs test, the grouping, the bilirubin, and the hematocrit. If the neonatal blood group is positive, no antibodies detected in mother, you give a full dose within those 72 hours. And what is this going to do is, it's going to bind to the antigen sites on the fetal RBCs in the maternal circulation and prevent the immune recognition also by the B lymphocytes. So it's an IgG antibody, anti-D is, and it's around 300 microgram would be able to take care for 15 milliliters of the fetal RBCs or 30 ml of the fetal blood cells and a half-life of 16 to 24 hours. But be careful when we have to give, it is not to be given anywhere into the buttocks, give it on the deltoid because there it goes into the subcutaneous tissues, it will not be absorbed, it will create a false impression, yes, you have given it. So give it on the anterior lateral aspect of thigh or the deltoid, and this will take care of preventing the stimulation of the maternal immune system. The risk and severity response increases with each subsequent pregnancy, we know. If there was no prophylaxis that we gave, it was 16% after 2 deliveries, 1.5 to 2% once occurs in antepartum, 7% in 6 months, and 7% manifest early in the second trimester. But look what happened. When we gave a prophylaxis, this risk really came down to 0.1%. But remember, there could be certain failures because we've not given a proper dose. We've not assessed the fetal-maternal hemorrhage. It was a too small dose. It was given later. And patient already immunized, but antibody titer too low for the laboratory recognition. Or it was a defective immunoglobulin which was given. So now she is Rh sensitized. This could depend on the volume of the hemorrhage that occurred, the extent of the maternal immune response, the concurrent presence of antibody ABO incompatibility, and when it's there, it's going to rescue it and the risk drops down to 1.5 to 2%. So there could be sensitization. Also, there has been a misinterpretation of the maternal Rh. Always remember to do a cross-check. Again, get the ABO-Rh done when she comes to you. Rh positive blood transfusion. It was an unprotected pregnancy and inadequate dose was given in any of the previous occasions. Check quantitative antibodies. Do a titer. And you see that at which severe anemia may occur would be 1:16. Then you have to monitor. Let's see how it is occurring. If the critical titer is less, if the titer is less than 1:16, you just keep doing the test every 4 weeks and you can continue this pregnancy up to 37 weeks. But now what happens when it is more than 1:16? You have to monitor the fetal anemia. And let's see, we could have, because there could be effects of fetal anemia, hydrops, fetal hyperbilirubinemia also. So we have got different options that we had till now were we could do amniocentesis, the CVS, the cordocentesis, and the free DNA also. The amniocentesis is done to study the optical density of this amniotic fluid, that's bilirubin, which reflects the RBC's hemolysis done at an optical density of 450, and that's going to be proportional to the level of bilirubin, and then we plot it into a Lilly's graph, which takes us into various zones. Now, these are the two charts which we're using. We find that the Lilly's was not accurate before 26 weeks, and the Quinan was much better because use it from 14 to 40 weeks, of course, and 10% superior. And look, we have the various Rh negative, unaffected, indeterminate, affected, and this, it would even bring out the risk zones to us. So this is how we manage putting into the zones. We keep following, which will be coming further also according to this Lilly's chart. Others are the cordocentesis, the fetal Rh and the hemoglobin, and a direct comb test. But now we are switching from all these invasive to non-invasive tests. We've got different gadgets of ultrasound, which is really, really helpful. And this ultrasound is going to detect it. It's going to see the fetal skin and the scalp. This is the halo sign. And there could be the fetal ascites also, and the fetal pericardial pleural effusion, the polyhydramnios in the mother, the hepatosplenomegaly, the fetal cardiomegaly, and the X-ray here done could give a Buddha posture over here, and the placenta will become really hypertrophied, enlarged. And why is this? Because there is a hyperplacentosis. It's an effort to increase the transfer of oxygen to the fetal red cells. And now we come to the most important is that with this we do a middle cerebral artery Doppler, the non-invasive test, because this is accurate. It's non-invasive. It will just tell you the moderate to severe fetal anemia. If you look into the chart, you find here at this PSV, yes, we have a mild form, and with this PSVs we go into severe form. The value for the peak systolic correlates with the severity of anemia. It's very easy to repeat it regularly also. It's got 100% sensitivity, but yes, 12% false positive rate, and it has resulted into 80% reduction in doing all the invasive tests, which have also could have been a cause of fetal maternal hemorrhage. But it is not useful before 18 weeks. And and causing her. So begin from 18 weeks, after 35, have a lot of false positive tests. So how do you live it? See over here, it's repeated monthly. Keep continuing with your patient 37 weeks. If that means you can see the systolic peaks are high, but how do you 1.5 multiples of median? Then you repeat it 1 to 2 weeks. You give steroid, have lung noti, and then take it till where you could stretch and then deliver her. But yes, if her MOMs multiples of medium are more than 1.5, frank evidence of fetal height drops, then she needs to be helped to be attaining the lung maturity and deliver, or decide for an intrauterine transfusion. So we could see that if this titer was critical, 1:16, you either do the hematocrit. If it's less than 30%, you go for an intrauterine transfusion. If more, you keep monitoring biophysical profiles, and also your middle cerebral artery could guide you. Yes, this patient without even the hematocrit, you could go for the intrauterine transfusion. So in severe hemolytic, we do this between 18 to 35 weeks. We could do it intravascular, we could do it intraperitoneal. The intravascular is much more preferred, and the hematocrit, if it goes less than 30%, we said we have to give the own negative packed cells which have a hematocrit of 80%. You cross match with the mother's cells, and they should be free of infection, and do not give a sample which is very prolonged. It should be within a week, and amount should be transferred, could be calculated the gestational age minus 20 into 10, and that's what you give more than 20 weeks. So it's tightly packed. You achieve a hematocrit of 75 to 80%. So this is the transfusion being done. And of course, you want to deliver her, see the suitability. There should be experience of the team, the type of delivery you're going to do, the medication. Are you going to get the facilities for the neonate, the fetus and the neonate, the phototherapy, and the exchange of the transfusion? So if we go into zone 2, 3, we have cardiac synthesis. We see for the hydropic changes, place her to a suitable place and do an intrauterine therapy, deliver her also, give steroids, do biophysical profiles for monitoring her, get her lung maturity. Sometimes cesarean would be required in a severe form of hemolytic infant in terms of 34 to 35 weeks also. So now while you're doing a cesarean section, just take care, prevent. Again, we know it's during the delivery that we have 90% of this fetal-maternal hemorrhage. We have to yet to save her. So prevent spillage of the blood from placenta into the peritoneal cavity. Spontaneous delivery of the placenta. Do not do any manual removals, and use your control card traction without squeezing the uterus. Avoid any avulsions to the cord. She could be delivered vaginally. If she's 37, 38 weeks, you could induce her if unfavorable with prostaglandins, or oxytocin if it's a favorable cervix. Do not do any fundal pushing in the first or second stage of labor. Withhold metagen till the anterior shoulder, and early cord clamping, and no milking to be done. Leave the length of the cord 15 to 20 centimeters. No massaging or squeezing in the third stage. Let placenta be delivered spontaneously. Avoid any avulsions. Protect vagina, perineal wounds, and lacerations for exposed to the fetal blood spilled from the cord. Now, of course, when you come to the postpartum management, you have to involve the neonatologist. He must be knowing you're going to deliver such a patient. And when deliver the baby, send cord samples for a direct womb test, ABRH, bilirubin. Also, if the fetus is negative, no further intervention. If it's positive, you determine now the dose of IgG that you need to give. You're going to give 300, or how much do you want to give? You go by a 4-step laboratory procedure, the Rosette test, which will give you a qualitative analysis, and you screen them. Then you see over there the clumps, that is a positive Rosette test. If it is negative, nothing. If you have a positive Rosette test, you go in for the Hak-Betke test to quantify now the RBCs in the maternal circulation, and we've already knew how to calculate them. So estimate the volume, calculate the dose of IgG to be given. If more required disease, or you've done some manipulation, so you need more, there could be hemorrhage, you have to adjust those doses. And of course, we have to manage the fetus. If there's a mild anemia, then you give a phototherapy. If there's moderate to severe, we could even go for an exchange blood transfusion. Mild hydrops to improve, but severe hydrops, mortality could occur. So there's special fetal-maternal risk stratifications, and abortions up to 5% chance of sensitization give 50 micrograms. If not available, maybe 150 micrograms because of the availability issue which is there. Invasive procedures, 11% sensitization, give a full dose. Antepartum hemorrhage, give a full dose to be repeated 12 weeks later if the pregnancy is going to last longer. And externocephalic version, 6% and you give a full dose. Non-invasive fetal, there are the advances that we need to do, the fetal cell-free DNA in metal circulation, the rapid tests are coming up, and the low 50 microgram dose preparation for the use following first trimester. And also we should take care now the concept of the partial D and the weak D antigens also. So to sum up, every woman should have a ABRH, obtain that of the husband also, ensure that the ICTs are done at 20, 24, 28 and 34 weeks, and a single postpartum dose may be inadequate, so be careful. Just analyze the fetal-maternal hemorrhage. A recent retrospective from New Zealand identified reason for continued cases of sensitization, including omission of this immunoglobulin after recognized sensitizing event in 41% of cases, and administration outside of the guidelines in 30% of cases. But there's so many problems and solutions. Yes, resources to educate and monitor fetuses, the low turnout for the antenatal clinics, yes, missed out, documentation missed, there are lots of case reports, and we need advocacy for partnership by government and NGOs to help us to subsidize this cost. And of course, the special insurance covers for RH women to ensure the ease of procurement when needed. So, advances in prevention and treatment of RH isoimmunization have been one of the greatest success stories of this modern obstetrics, is according to the ACOG Practice Bulletin. The first introduced the RH immune globulin reduced the rate of alloimmunization from 13 to 16% to now to 0.5 to 1.8%. And of course, the risk reduced further 0.14 to 0.2 with antepartum administration. So despite considerable proof of efficacy, there is still a large number of cases of alloimmunization because of the failure to follow all these protocols. So there are new data now to help guide this management, especially now regarding the weak D phenotype women, which is also to be taken care. So any tragic event really hurts the life. But this cry brings you back your dreams and a bundle of joy. So it's only hope. So sometimes hope is only thing. And once you have it, you have everything. Thank you so much for a very patient hearing.
Thank you, Ritu ma'am, for such an enlightening talk. Hello. Thank you, Ritu ma'am, for such an elaborative and precise talk on RH isoimmunization. I would like to invite Manjari Mata ma'am to proceed with the discussion regarding the topic with other chairpersons. Manjari ma'am. Ma'am, you have to unmute yourself.
No?
Ji ma'am.
Am I audible?
Audible ma'am. Yes ma'am.
Ritu has very nicely elaborated on the subject, and I need not add anything excepting the problem of RH incompatibility is a complex one, but if managed properly in time, that is from the very beginning, and if the RH negative woman is unsensitized against RH antigen, the fetus is unaffected. However, if not managed properly, as most of the time occurs in our country, in rural areas, and even in the urban area, the patients don't know their blood groups even in the second and third pregnancies. And when they come to us, their blood groups are done, and then they come to know that they are RH negative and the husband is positive, and there is problem of incompatibility. The condition could be disastrous, and the babies are affected. The prognosis may be poor. The prognosis depends upon the genotype of the father, as she has already said, genotype of the fetus, maternal antibody levels, history of previous babies affected with hemolytic disease, and availabilities of the facilities for the management of affected babies. This is very important. Not in every center we are able to manage these babies, and repeated fetal middle cerebral artery Doppler studies amniocentesis, chordocentesis, intrauterine fetal transfusion, and exchange transfusion have revolutionized the management of these cases, and the neonatal survival is 100%. Administration of anti-D gamma globulins in the antenatal period and in the postnatal period is useful for the future pregnancies, and breastfeeding is not contraindicated in these cases. I want to say that. And regarding phenobarbital, we used to use phenobarbital to help the conjugation of the bilirubin by enhancing the glucuronide transferase enzyme, and sometimes that is also used. That is all I want to add. Thank you very much.
I would like to invite Dr. Ashok Kumar sir, Professor Ashok Kumar sir, to just pass few expert comments on this topic, please.
Am I audible?
Yes,
Hello?
sir.
Yes.
Yes. So good evening. Before I comment on the talk, I thank Dr. Uma ji and Varanasi Society for inviting me and giving this opportunity to interact with the Varanasi Society. Thank you very much. And Dr. Ritu has done a wonderful job. She has covered almost everything in the shortest possible time. And this talk is useful to undergraduate as well as postgraduate also, because she has touched all these basic concept of RH isoimmunization also. This is very important now to understand that middle cerebral artery, peak historical, is now becoming a very common and routine in the management of RH isoimmunization. And Lily's chart and all these are now, I think we are not using much now. The second thing which is important is, and upcoming, is cell-free DNA. If we have the facility to find out the fetal genotype, then probably we can do some exercise to prevent RH isoimmunization also. So that is a recent coming up thing, and but although we don't have much facilities now to do cell-free DNA, the third issue and what we face is, I don't know whether you are also facing this problem or not, the dose of NTD, because we don't have this 51 which is available or 100. We have always this 300 one. So we have to give always, because there was some confusion and we read extensively about the dose of NTD in abortion and everything. But now they say you give, because when we were undergraduate, we used to read about 50 microgram and 100 microgram depending on the gestational age. But now they say, and since it is not available, so we give the full dose only to all these patients. So that is the practical problem which is faced by all of us. Thank you very much, Dr. Ritu. It was wonderful talk and we learnt a lot. Thank you very much.
Thank you, sir. Thank you for your comments. That was nice. Thank you, sir. Vanita, back to you.
Yes, ma'am.
What about higher doses of anti-D in cases of twin pregnancy? Sometimes it is said a larger dose is required for twins and certain special
I think
circumstances.
the twin pregnancy needs to be given the same dose. But if there is any fetal maternal hemorrhage, then the dose has to be calculated and more number of anti-D ampules as 20 micrograms for 1 ml of the fetal. That has to be calculated and you can increase the anti-D ampules.
But Dr. Ritu, unfortunately, we are not able to calculate the dosage because we don't perform Kleber-Beckett test, do we? So in that situation...
So they say that if you're not able to, so you can give an extra dose also of that. It's better to cover more than to be on a lower side.
I have read the double dose of say 600 micrograms should be given in twins, and
it's expensive. NTD is expensive for our patients.
Yes,
it's expensive.
Government hospitals, it's expensive. Okay.
Okay. Thank you, Ritu Khanna ma'am, for such an precise talk.
In MCH program.
Thank you all.
Free in MCH program.
Yeah. Nisha ma'am is there. Vanita, Nisha ma'am is there.
Yes, ma'am.
Yeah, NTD is these days free in MCH program for our patients.
But even then, they won't allow us to give 2 doses in a woman because it is the budget is limited for the woman. I mean, our JSY has a budget and particular sort of medicines now.
That is
Nisha ma'am, what
rarely
do you say?
required.
Nisha ma'am, what's your opinion? Like, we need to give a double dose, our Asha ma'am, for the twins? Do we need to give them?
I have never given a double dose, so I don't know.
Even I have not given, but I have read it.
Yeah. Till like we just know that if depending on the fetal hemorrhage, yes, we need to increase, and we can.
Yeah.
The double dose giving is always beneficial. So
One more thing, I
Right.
just want to know, Dr. Ritu. Hello.
yes, sir.
Are you giving antenatal single dose or 2 doses as 28 and 32? Or you are giving only single dose at 28 weeks?
So actually, the preferred is the 2 doses, one at 28 weeks and then again at 34 weeks. But depends really on the compliance of the patient. If not, at least one at 28 weeks. But we prefer to give 2 doses.
Thank you, Ritu ma'am, and all the chairpersons for the expert comments. Now we proceed for the next talk. Next talk we will be having on domestic violence from Mr. Lindo sir. I please to invite Nisha Rani ma'am to introduce Mr. Lindo sir. Sir will be talking on domestic violence. Nisha Rani ma'am.
It's my privilege to introduce Dr. Stephen William Linder. He is MB, CHB, M Medicine, Obs and Gynae, MD, FRCOG, FCOG South Africa, and FRCPI. He is Director of Master's Project, Coombe Women and Infant University Hospital, Dublin, Ireland. Honorary Professor of Obstetrics and Gynecology from University of Cape Town, South Africa. And recent past positions were from 1614 to 1218, Head of the Division of Obstetrics, Sidra Medicine, Doha, Qatar, and Professor of Obstetrics and Gynecology, Weill Cornell Medical College in Qatar, Doha. From 93 to 14, Consultant Obstetrician and Senior Lecturer in Obstetrics in Hull York Medical School and Hull and East Yorkshire Hospital. From 82 to 93, Consultant Obstetrician and Gynecologist at University of Cape Town, Groote Schuur Hospital and Somerset Hospital, Cape Town, South Africa. He has published more than 190 publications on a wide range of obstetric subjects. Now over to you, Dr. Stephen.
Thank you. Can you see my slide?
No,
Yes,
Yeah, we can,
no, I can't see.
not the slides,
we
you.
can see you.
I see slides.
Not the
Oh.
slides.
Sorry.
So, Screen share the green one.
Share screen.
I can't seem to get it actually. Sorry. Let me just. I've gone right through the talk now. Just finish it off now. Right now. Let me see. Where am I now?
At the bottom, there is the third number is share screen, green
Right.
color.
Yeah. Let me have a look. No.
You did it rightly yesterday, Mr. Lindo.
Yeah, no, I fixed it up yesterday. It worked well. Let me just see if I can. Can you see me?
Yes, we can see
Yes,
you.
sir.
You
see,
are visible.
I've lost everybody.
Yeah.
Can't you see the green one, share screen one, in the bottom of the screen?
No, I'm not getting that at all.
You click the small dots below. Can you see small dots?
Mr. Lindo, why don't you leave it, Zoom completely and come back to us?
Okay.
Sometimes that helps. I've seen many times that helps.
Okay, let me try that.
And then if it doesn't happen, then we'll ask session to help him out.
That's better. Yeah, now. So share screen. Got you now.
Please, yeah.
Yeah, and let me just call that up.
You opened your PPT in your desktop or laptop already? PPT is open?
Yeah.
Okay.
So once you press the share screen button, just choose the option as screen. That's all.
Yeah.
He's not able to get the green button also.
No, he got it now.
Can you see now?
No.
Support, can you just request for a control of... Oh, okay. Now we can see.
Got it, Mr. Lindo.
Righto, got it.
Well done,
Yeah.
you.
Have we got it?
Yeah, we have.
Oh, brilliant. Thank you very much. Sorry. Too much technology. First of all, thank you very much to the Varanasi Obs and Gynae Society for asking me to come to speak there. It's such an honour, and I've really enjoyed the presentation so far as well. It's been really very informative. So lovely presentations. But as we've gone from science, we're now going to society to talk about something a little bit different. So we're going to talk about intimate partner or domestic violence, various different names across the world for it, and the obstetrician. I want to specify the obstetrician. And as I say, when you look at my titles there, I'm now working in the Coombe Hospital in Dublin, in Ireland, and I've got an honorary professorship from Obs and Gynae from the University of Cape Town. And previously, I've been working in this place in Qatar. As you can see, 30 years ago, it was just literally a desert. And then that's the big built-up area of the West Bay of Doha, where I used to live for 5 years. So it's changed that from a desert to a big metropolis in 30 years. And you're going to hear a lot about it in the coming years because the World Cup's going to be there in 2022. I'm sure not necessarily all of you are World Cup interested, but anyway, that's how it is. So we're going to be talking about domestic violence and the obstetrician. Now, if we look at maternal mortality reports going back centuries, back to 1840, we've got improvements in sanitation and nutrition, antenatal care, the formation of the Royal College in 1927, that did nothing. But what actually did change maternal mortality was antibiotics, bank blood, surgical improvements. This is what reduced maternal mortality in the 1940s onwards. In other words, our predecessors, the consultants from years ago, actually looked upon that sort of those new innovations and embraced them. They brought them into their practice to reduce maternal mortality. They were open to new things. And this is where we've gone to when we look at maternal mortality from the United Kingdom, deaths for maternities. We've gone right the way down from really quite horrific figures in the 1950s, right down to where we're at now. Low levels as we've gone all the way through with maternal mortality, as again, the baseline levels that we've got to now. And these have been achieved by taking problems, looking at problems in isolation, taking problems, and then instituting solutions to those problems. Now we look at the deaths from thromboembolism. Back in the 1950s, they were almost entirely due to deaths from women who delivered vaginally. These are the blue segments to the columns there. And these have been reduced massively by introducing the situation where we've stopped the lying in period. People used to lie in for 1 to 2 weeks after delivery, and these women used to get thromboembolism and die because of the result of it. But better knowledge of the physiology, the reason to get women up after childbirth, to get them mobilized, has actually reduced the number of deaths from thromboembolism. In other words, we took a problem, intellectualized it, thought about it, and produced a solution. Another thing that we did in the United Kingdom was change the law. So we looked at direct abortion deaths, the illegal abortions that were outlawed in 1967, the 1967 Abortion Act. And again, those illegal abortion deaths have gone right the way down. So in other words, we took a problem and changed the law to deal with that problem. And that was embraced, although a little bit slowly, but that was embraced by the profession to improve women's health in the wider sense. Now, if we look at vulnerable women, we can ask ourselves, is this an obstetric issue? In the earlier reports, something like 60% of women who died, 11% of the women who died had actually had evidence of drug use in pregnancy, and 1 in 7 of the women that died died because of domestic violence. There was 19 cases of murder in one report, all of pregnant or puerperal women. And we've got to ask ourselves, is this an obstetric issue? Is it our problem to deal with? Well, if we look at across the board there, where we look at murder, psychiatric causes, genital sepsis, hemorrhage or early pregnancy problems, murder is on the scale. Murder is the same sort of level as these problems that we've dealt with, that we learnt about and that we've dealt with for decades. But murder is now there. And in fact, murder's always been there. It was just shaded by problems in other areas, such as thromboembolism, preeclampsia, abortion-related deaths. Murder's always been there, but as we've solved all the other problems, the incidence of those other problems have come down. Murder is now standing as a problem that needs to be sorted out. And what I would say is it's our generation that needs to embrace a new problem, i.e. domestic violence, that our previous generations had actually embraced when they have looked at the problems that they faced and then they solved them. Across the world, domestic violence in the red there is a big problem in Europe and in Asia. It doesn't seem to be that bad in Americas, but it might be because of the large other group there. I think that might be a difference with classification, because we do know that domestic violence is a problem, particularly data out of North America, who've led the world in the recognition of this as a problem. But we see, as I say, it's a global issue with respect to domestic violence, global homicides, Europe and Asia particularly. Domestic violence is right there as a problem that we've got to face. Is it actually an obstetric risk factor? Now, one of the first people was my colleague, Joe Shumway. He was one of the first people going back 25 years when he looked at it. Joe Shumway then looked at the issue relating to preterm labour. And he found that when the women weren't abused in pregnancy, and this was in the United States, he was looking at this, the rate of preterm labour was only 3%. But moderate violence pushed that up of the order of 4 to 5 times, and severe violence 5 to 6 times that sort of rate. In other words, that there was significant difference in the rates of preterm labour when women experienced moderate or severe violence in pregnancy compared to the woman who didn't have violent pregnancies. This is very important to realise that this is an independent obstetric risk factor. There's been over 50 observational studies now to look at that. If we just think about the confidence intervals then, the preterm birth, low birth weight, odds ratios, then it's around about double. In other words, a preterm birth rate, and we recognise that as a big problem that we face in violent pregnancies, is double, and low birth weight babies are double the incidence in violent pregnancies than they actually were in non-violent pregnancies. So if we ask ourselves, is this an obstetric risk factor, not a risk factor for women's lives only, but an obstetric risk factor? Yes, it is, because it's integrally related. It's clearly related to the problems, one of the biggest problems we face, and that's preterm birth and low birth weight. If we look at the chance of the baby dying, fetal and neonatal death, a meta-analysis of all the studies that have actually been done. And notice on the left there, some of these studies have come from India, as well as the United States, Ethiopia, Brazil, Australia, right across the board there. Then again, unspecified inter-partner violence, that's domestic violence. Inter-partner violence is actually increases the rates of the neonatal death as well. So it's very, very clear that across the board, that domestic violence is not only a society's problem, it's not only a problem for women, for women's health, it is independently an obstetric problem that will lead to a significant increase in the chance of fetal and neonatal deaths. So it is our problem, I would say. It is obstetricians that need to address this issue. Looking at this was a thing from America, from more than 1,000 African-American pregnant women, Schneiderman and Keeley, looking at quite an unusual, because things are different in different countries. Quite obviously, you ladies all know that, and I know that. But when we look at the biggest rates there, they were looking at almost 40% of interpartner violence. But the biggest group were reciprocal violence, where the woman was violent towards the man and the man was violent towards the woman. These were all pregnant women in violent relationships, but they were mutually violent relationships. A smaller group were perpetrators only. In other words, this was where the woman was violent towards the man. And then a smaller group even then with the victims only group. And again, this maybe data doesn't travel that well, because that isn't the case in the United Kingdom, for instance, and I don't think it'd be the case in India. But under the circumstances, with this unusual set of cases, we can see that very large study that they did was, the biggest group was reciprocal violence. And if we look at them, when we look at their rates of preterm birth, when the woman has been the perpetrator only, in other words, she has been the violent partner, more than 100 cases are looked at, the rates were less than non-violent pregnancy for preterm birth. But the red numbers there are significant. When it's a victim only, the victim only in this case, that was where it was more than double to treble the rates of preterm birth. Even severe or minor or physical, apart from sexual. But as I say, severe or minor interpersonal violence and physical only interpersonal violence. And again, then it was double to treble the rates of preterm birth. And reciprocal violence didn't seem to be a risk factor that was significant at all. So it is a complicated area, whether the woman beats the man beats the woman, or in fact they're violent towards each other, is a very, very complicated situation. And as I say, we're just starting to learn the complexities of this complex problem. So if we define domestic violence, any incidence of threatening behavior or abuse, psychological, physical, sexual, financial, or emotional, between adults who have been or are intimate partners or family members, regardless of gender and sexuality. It's a wide definition, and there are other definitions. It's not the only definitions, but again, we don't want to get tied down, because I think we all know what we're talking about. It's the woman's safety in her own home that we're actually talking about. We did a study back to the mid-1990s in the United Kingdom. And we looked in secret. We let these women go into the blood room at our old hospital. And we put a sign on the door in the blood room when there were antenatal women going in to have the bloods taken. No partners allowed in the blood room because of a recent incident. So the women went into the room themselves, closed the door. They had the blood work done. And then there was a little cubicle in the side of the blood room surrounded by curtains. And we said, do you want to go into that cubicle? They went in the cubicle and there was a questionnaire for them. And then they filled in the questionnaire and put it in an anonymous box at the end of it. So we didn't know who filled it in. It was the first big study done in the United Kingdom. We didn't know who filled it in. And as I say, the woman could put anything that they wanted. But we did 500 consecutive women into the blood room and 475 filled it in. Only 25 women didn't fill it in. And this is quite incredible when you think that at that time, the head of midwifery tried to have the study stopped because she said it wasn't ethical to ask women these questions about their personal lives, about their domestic situation. But under the circumstances, she didn't manage to get it stopped, and we carried on. And we found that 17% of the women, around about one in six or so, had actually had suffered incidents of abuse. And as I say, only 25 out of 500 didn't fill it in. They put the form in the box blank. The pattern of violence was slaps, threats, weapons, punches, and burns. And the burns was a nasty little local habit where the men would stub cigarettes out on the woman's skin, give them a little circular burn mark on the skin. Really quite unpleasant. The perpetrators were ex-husbands and boyfriends, fathers and mothers. But then when you look at strangers, and we asked them who the stranger was, if there was a stranger involved, the stranger was things that you can't quite work out, like my mother's boyfriend, or my mother's new husband, or my brother-in-law. In other words, because of multi-generational households with various different aspects, it wasn't precise who was actually living in the house, but the woman was suffering domestic violence in the house by somebody that she had no blood or marriage relationship to. In other words, as I say, some of the unusual ones were my mother's boyfriend, for instance. So that's where the stranger bit comes into it. Right across the different age groups, it's not something new and it's not something old. It occurs in every generation that we looked at. And across the United Kingdom, this is the British crime surveys I'm going to report to. So they're not crimes that have actually necessarily been reported. These are surveys of all the citizens in an area where the citizens are asked, have you suffered from this? Because somebody might suffer domestic violence and not go to the police. That means that her experience isn't recorded. But under the circumstances, she's then asked her opinion, and then she puts down that she's suffered domestic violence, then that's where it is. So the British Crime Survey and the police statistics don't exactly mirror each other. They're not exactly the same. But the British Crime Surveys are thought to be very accurate because people give an honest opinion of what they underwent. So, I don't know, somebody could steal a lawnmower from my garage and I wouldn't necessarily report it to the police because it's such a small thing. But as I say, but if the crime survey came, I'd say, yes, I've been subjected to burglary. If we look there, then we're talking about, for any domestic abuse, around about 20% there. So that's about 1 in 5 British women are actually ever suffered that. So 16 to 59, and since the age of 16 years old, so as adults, they've actually suffered any domestic abuse. And some unusual things like stalking is coming into it, being followed around by family members to make sure that they actually obey various family rules and what have you, whatever it might be. Indicators of domestic violence in antenatal patients, because this is where we're talking about, domestic violence in the obstetrician, this is where we're seeing our patients. The majority of times is actually in the antenatal clinics, and it's very, very, very non-specific, as you can see. Late booking, repeat attendance for minor injuries, non-compliance with treatment, depression, anxiety, self-harm, injuries, signs of abuse on the body, STDs, vaginal urinary infections, repeated miscarriage, unwanted unplanned pregnancy, the constant presence of a domineering partner, woman appears evasive or reluctant to speak. And in the United Kingdom, we try to make sure that every woman is seen on her own in pregnancy at least once. So in other words, if there's something she wants to say, there's not somebody sitting in the same room with her husband or with her husband's mother or with her own mother or whatever it might be, that she's in a clinic, that she's seen in solitary herself on her own, so then she can disclose things that she might want to disclose. Now, if we think about it, we're going to be talking about the gender, about the classic. There are 78% male offender and female victim. But this is not the whole story. When we look at the 9% there, where you have a female offender with a male victim, this is a lot less common, and male-male relationships and female-female relationships both have evidence of the same problem. In other words, it's a problem within human beings' relationships rather than anything. But because of our chosen speciality and our talk about obstetrics, we're going to be concentrating on the male offender and female victim scenario. But it's not the only way that it plays out. It can play out in different ways. But as I say, because of our speciality and what we are talking about obstetrics today, then we're going to be talking about a male offender and female victim. What about alcohol? Drinking is thought to be a big problem. And if we look there, 18% alcohol where the victim and the offender were both under the influence, or 16% where the offender was under the influence, but the victim was not, the victim was sober. But the biggest case, when neither of them were, 32% in these cases, neither the victim or the offender were under the influence of alcohol. So alcohol is related to this problem, but not actually the problem. It's an inflammatory aspect in the problem. It's not the core problem. The core problem is not alcohol related. And just to comment there, about the drug use, lesson 1, right across. Drug use. It's very, very unusual to actually have domestic violence related to illegal drug use in the United Kingdom. Now, if we just talk about drug use for a second, we look at this study from Stewart looking at victimization, and these were women. These were woman victims who were in a batterers program. And basically, when we looked at the alcohol aspects, and if we look at alcohol and heavy drinking, severe physical and any violence were more common on drinking days than non-drinking days. So looked past the last couple of months with them and found out what happened on what day, and then worked out whether they'd been drinking on that day or whether they hadn't been drinking on that day. They also looked at marijuana and opiates and cocaine. And you see how unusual it is with respect to the sexual aspects related to cocaine use. And then in addition, when you look at marijuana and opiates both had a major reduction in domestic violence on the days that the individuals had been taking marijuana or opiates. This is important to realise, that although alcohol is related to domestic violence, the actual act of drinking makes it more likely that somebody will commit or be a recipient of domestic violence, be a victim of domestic violence. But although drug use is related to domestic violence, the actual act of taking marijuana or opiates makes it less likely that individual will become a perpetrator or a victim. Cocaine is the unusual one. Cocaine doesn't fit the bill. Cocaine is different to opiates and marijuana. And this is the same study looking at the perpetrator. This is where the woman has been a perpetrator of violence. And again, it's the same story. More common when she's been drinking alcohol, more common when there's been heavy drinking for violence, and less common if she'd been taking marijuana or opiates. As I said, just to reiterate, domestic violence is more common in women who take alcohol, but under the circumstances, if she takes alcohol, she's more likely to commit violence or be a recipient of violence. But although drug use is more common, if she takes marijuana or opiates, she is less likely to commit or be subjected to domestic violence. It tends to, on the specific days, tends to reduce the incidence. So we look at the income as well. It's interesting just to look at data like this because this has relevance to India, as I'm going to point out just now. Then we look at the rates of men who've been victimised with domestic violence and women. And clearly there is an income related. Those at the top earning less than £10,000 a year, and those at the bottom earning more than £50,000 a year. You with me? So when we look there at £10,000 or £50,000 a year, then under the circumstances, sorry, somebody just come into my door. Then under the circumstances, £10,000 or £50,000 per year, then this is where we're looking at with respect to more common in the poorer people and less common in the rich people. And that's where we're at. Can I just go out for a second? 1 second. Monica, can you answer the door? I am sorry. Somebody's come to my door. So with respect, so what I'd like to point out though, that there is still domestic violence in the rich people. If you think a bank manager or a scientist or a doctor can't commit these problems, then you're wrong. Yes, they can. They are more common in poorer people, but not exclusive to poorer people. Strangely, when they looked at the crime survey, what people think, when it's mostly acceptable to hit or slap the partner compared to different behaviours, look at men and women, men in the blue, woman in the yellow there, and constantly nagging and moaning, flirting with other people, having an affair or cheating. It's very strange that men and women had virtually identical answers to this. As men and women felt that under the circumstances of domestic violence, then it's a difficult sort of situation that men and women perceive it the same to be equally bad themselves. There's not a difference in the perception of what constitutes appropriate or inappropriate behaviour. Men and women are the same on that respect. They both consider that having an affair, it's still only 5% of women, 5, 6, 7% of women and men say having an affair is cheating as a reason for domestic violence. Now, moving on, when we look at England's football matches, when England plays soccer in the World Cup, and this is where we're looking at violent incidents, domestic violence, when major England match days, when we looked at the games with Paraguay, Trinidad, Sweden, Ecuador, Portugal, you with me? Then the blue ones on the match day or the same weekday, which wasn't a match day, then under the circumstances, there's much more violence on any match day than there was when there was no match day at all, the same weekday without violence. This is one of the strange things when we look at it. If we look at other crimes on the same days, Paraguay, Trinidad, Sweden, Ecuador, Portugal, again, no difference. No difference. And this is not a badly drawn graph. Let me just flick between the two, the same axis. And you see how many domestic violence episodes there are on those days compared to all other crimes, recorded crimes in those days. Domestic violence was by a multiple the dominant crime on match days and non-match days. But strangely, when it's a match day, then again, maybe it's the emotion, the alcohol, the change in circumstances, whatever it is, domestic violence is much more common when in fact England are playing football. And I wouldn't be surprised in any country, say if India has a big cricket game against somebody in the World Cup, I wouldn't be surprised if that's the same there as well. It's something to do, again, with maybe the emotion or maybe a group of men getting together. I don't know what it is. If we look at the calls for police assistance with domestic violence marker, back to the socioeconomic status. We look at the ones on the left, City of London and Cheshire and Lincolnshire, your Surrey. These are posh areas of England. These are where the wealthy people live. We look on the areas of the right. The worst one of all is where Uma Pandey and I worked, and that was Humberside. Uma's worked for years in Humberside, and Uma Pandey and I worked together there. Humberside was by far the worst. But again, it's a relatively poor area. And this just mirrors the issue that it's not unheard of in expensive areas by educated people, wealthy people, but it is more common in poorer people, but not exclusive to them. Pinky Singh, when she worked with us, she did a study using our same methodology that we used in Hull, the same questionnaire, the same methodology, but it was translated, as I say, and we used it in Kasturba Hospital in Delhi, where we interviewed more than 1,000 women there. And as I say, what we found from the Delhi aspect was a total of 26.9% reported physical abuse, emotional abuse 29%, sexual abuse 6%. It was similar from women, different religions or ages, but it was higher in poor, less educated women and women who had witnessed abuse in their family circumstance when they were growing up. Husband were the main perpetrators, and other family members are 31%. In other words, what I'm trying to say is what we found in the United Kingdom was virtually the same as what we found in India using the same methodology. There wasn't much different at all. The only slight difference was the other family members' bits. Maybe more common to live in multi-generational households in India than the United Kingdom, I would have thought. And as I say, under the circumstances, that 31% was just probably the only actual difference between the Indian study and the United Kingdom study using the same methodology. The majority of women reported no control over their lives, and the majority of women didn't contribute to family decisions, which again, although not physical, it is another form of abuse. In other words, taking somebody's decision-making capacity, their ability to contribute to the family decisions, taking that away from them, it is a form of abuse. So risk factors to domestic violence in pregnancy, serious levels of violence before pregnancy, feelings of inadequacy, jealousy and controlling behaviour, partner intravenous drug abuse, low social class, poor education, and social deprivation. But these are not exclusive. That's what I've just pointed out. And as I just to reiterate, these are not exclusive. They're very, very soft markers for risk factors. We looked at medical complaints in our women in the gynecology clinic. We found out that significantly more women with abdominal pain, painful periods, painful intercourse, smear abnormalities, cancer worries, and bowel symptoms were evident in the domestic violence cases. And I think domestic violence doesn't cause any of these things. What I think is that it just reduces a woman's resilience to cope with the things like painful periods and abdominal pain, etc. In other words, it's her resilience, it's their background to domestic violence is that her ability to cope with the lumps and bumps of life is actually reduced. With Tonya Wakoma, we looked at domestic violence in women in the United Kingdom who request a termination. As I've pointed out, we have a very liberal termination law, and we have termination clinics. So women go 6, 8, 10 weeks pregnant, say, I don't want this pregnancy, and book for a termination of pregnancy. But under the circumstances, they go 6, 8, 10 weeks and book for antenatal care because they want to keep the pregnancy. So we did the same questionnaire to 507 women in the antenatal clinics and the termination clinics. We found, roughly speaking, a 5-fold difference between physical abuse and emotional abuse. In other words, it was 5 times higher in the woman who requested termination than it was in the woman who'd requested to keep their pregnancies. And then when we asked them why they were asking for a termination, the top one by a long way was money worries and contraception failure. And then relationship issues. If we just look right down to the bottom with a violent relationship, 10 out of 527 reasons for a violent relationship. So one of the strange things that we found was that although a woman was in an unsatisfactory relationship, a more violent relationship, more physical abuse, 5 times more emotional abuse, she didn't constitute that as a reason to ask for a termination. Even amongst other things as well, even when she put 2 and 3 reasons down, that was rarely given as a reason not to continue the pregnancy, which is very strange. I would have thought that if a woman was in a violent relationship, she would think, I'm not going to bring a baby, a child into this violent household. You with me? But in fact, that wasn't a reason for women's request for terminations. It was down to contraception, marital relationships, and money worries were the main things. So if we look relationship factors and condom use, women with high levels of inter-partner violence had more unprotected sexual episodes, and low relationship power, fear of abuse, and partner dependence were associated factors. In other words, the woman in this violent relationship, or emotionally and physically, doesn't have a lot of reasons in that relationship to govern her own life. And this, at the bottom, if we look at unplanned pregnancy, sexually transmitted diseases, urinary tract infections, all at the bottom there were actually increased. But because of that, there's condom use negotiation, reproductive coercion, decreased contraceptive use, risk-taking behaviours increased, and just a lack of control over her sex life, her relationship life, and then the lack of control over the number of children and how they're going to plan the family and what they're going to do. You with me? This is where it all comes from. So in other words, that the inter-partner violence actually fed into this dysfunctional relationship that ended up with more women at the bottom with respect to unwanted pregnancies and STDs. Can we make a difference as doctors? We've not always got it right. As I say, we can, but can we make a difference? This is where we're coming to domestic violence and the obstetrician. Well, if we look, simple thing is, teach the men how to behave. The only trouble is, it doesn't work. As I say, when we look at behavioural therapy for men who physically abuse a partner, there is no validated way of changing violent men's behaviour towards their partners. It's a stark reality that whatever people have tried, it does not work. That's the problem. You know what I mean? It's a difficult concept to believe in. but that is the reality of the situation. Men's behaviour is not open to corrective treatment. Just to throw something into the pile, we know that men who grow up in violent houses more likely are head of a violent house when they become adults. But when they've looked at genetic markers relating to impulsive behaviour and lack of self-control, they found that violent men more likely have these genetic markers. It is possible, I wouldn't like to say it's proven, not by a long way, but it is possible that under the circumstances, there's a genetic reason for men's behaviour to actually end in a violent relationship. As I say, control for drugs, alcohol, length of relationship. There's not a domestic violence gene. There's not like a domestic violence like the rhesus gene, what have you. It's nothing like that. But under the circumstances, it may be that inability to regulate their own behaviour, impulsive behaviour, aggressive behaviour is actually genetically controlled, and that leads to domestic violence. So how are we going to do it? And I may just ask something to the audience, that if I say that it's a problem, and it is a problem, it's not something that we want to see or suffer from or be associated with, and we can't fix the men who do it, perhaps we're talking about just the way that human beings are made. Is this not a flaw in the human condition? It's in every society, it's in every social class, it's in every educational class, it's in every religious group, it's across the world, it is wherever you look for it, it is there, and we can't fix it. We have no way of fixing the men who are perpetrators. Perhaps is this not the way human beings were? With the hunter-gatherer, with the fighting between various tribes as human beings developed over the last thousands of years, is this not the way that human beings are, and that we'll never actually fix it? On the other hand, when we look at Jukes's way of actually looking at it, where you've got the personal aspects on the right, the interpersonal, the institutional, and society, with different laws, different norms, different parenting models, you with me, with education programs, with changes to institutional cultures. Maybe this is how it's actually all going to happen. And when I look back there at my school days, we never had girls who were part of our group. We had a group of boys. We played rugby together. We went to university together, etc. This is how it all went. But these days, when I look at my son and my daughter, they have friends right the way through school who are friends now, who are of the different sex. When the son comes back to the United Kingdom, he looks up some of his girlfriends, or not girlfriends, not romantic girlfriends, but he looks up some of his friends who are girls. And my daughter has a group of friends who are actually boys. One of her best friends is a married man who's married somebody else, and she's never had a relationship with him, but they're actually great buddies. They see each other all the time. And this is maybe the way society's addressed it, rather than under the circumstances, putting the offenders in a education program to change their behaviour. That doesn't work. Maybe society, education, schools, and the way that children interact is going to change, and that's going to change it. Now, back to domestic violence and the obstetrician. Jukes, who's written a lot about this, says screening of domestic violence in asymptomatic individuals leads to improved health outcomes. Does it? The 3 randomized controlled trials, there's no evidence of improvement. Number one, we don't specifically have a treatment to the problem. And screening for domestic violence, and we've talked very nicely earlier on about screening for rhesus, but we've got a treatment for it. We can get the rhesus, and we can actually then evaluate whether the baby's positive or negative. We can do the middle cerebral artery Dopplers. We've actually got a treatment for this. We can actually institute something that works. With respect to domestic violence, the 3 randomized controlled trials indicated it doesn't work. We have nothing to offer these people, so why should we screen? There's only one problem with that: pregnancy. Pregnancy is the difference, and this is where we're coming to with domestic violence and the obstetrician. Pregnancy is different. So when we look, women don't mind being asked, in the United Kingdom at any rate, they didn't mind being asked about it. When the patients actually indicated, should staff encourage victims to tell the police? 89% said yes. So patients were very clear that they didn't mind being asked about violence when they attended accident and emergency. And we did a midwives education program to make sure that the midwives were confident in themselves. Do you feel equipped to deal with the situation? Well, after training, it went up to 46%. It was only 10 before. But as I say, to help the midwives have the confidence to ask women, are you all right in your home? Do you feel safe at home? Now, if we look where we come to with Keeley's randomized controlled trial with domestic violence and the obstetrician, African-American woman with positive histories of domestic violence, 521 went to intervention and 523 went to usual care. The intervention was social workers and psychologists interviewing the woman, 4 sessions minimum and up to 8 sessions of cognitive behavioral therapy with the emphasis on safety behaviors. In other words, it took the woman to find out what were the circumstances when she became the victim of violence. What was it? Whether it was arguments, whether it was discussions, whether it was alcohol, whatever it was, and taught her safety behaviours, taught her how to get out of that dead end where it was going to end in violence, how to talk a way out of it, how to avoid it, how to intellectualise the discussions that went on to avoid violence. But note, this was the emphasis on the woman, not the man. When I was talking about no treatments, that was no treatments for the men. This is the woman involved, and these were the women who were then targeted, not their husbands. And this is what it looked like. Everything in red is significant. So the intervention group had half the number of further episodes in pregnancy, more than half the number, a reduction in episodes in the puerperium. Let's say physical violence was reduced by a half. And as I say, severe violence was also reduced by a half in the puerperium. So right across the board, the safety behaviours, the safety techniques, the negotiation techniques that were taught to these women actually worked. They reduced violence. But specifically with obstetrics, reduced preterm delivery. If we look at very preterm delivery, 6.6% versus 1.5%. Back to where we started off with Joe Shumway's work, that violence is related to preterm birth. These safety behaviours the women were taught and encouraged to use, the education of the woman to get out of violent situations, actually reduced their incidence significantly of very preterm delivery and increased the gestational age at delivery significantly. This is incredible. And when we look at that last figure, 1.5 versus 6.6 for very preterm delivery, there's no drug on the market that do that. Torsiban or nifedipine or whatever you want to choose. And there's no drug on the market that's even thought to reduce preterm labour by that amount. This has also been backed up by a Chinese study as well, which found similar results. In other words, it does seem that 2 things. Number one, it is worth screening domestic violence in pregnancy because we seem to have a treatment that will actually reduce the obstetric outcomes that we're actually worried about, such as preterm birth and preterm small for gestational age. In other words, this doesn't work outside of pregnancy, but the focus is perhaps coming on us in pregnancy to reduce a problem that we actually have. So we've come a long way. This is a journey that we're on, but we've come a long way. There's a historical perspective. And I just want to outline some of the way things have happened in the United Kingdom. A rule of thumb, 1857, it was legal and acceptable for a man to beat his wife, providing the stick he used was not thicker than his thumb. And again, it's in common English usage, or rule of thumb analysis of this, that, and the other. We often use the term rule of thumb. That's actually what it means. That's where it comes from. It's acceptable to beat your wife with a stick that's not thicker than the thumb. Secondly, there's a curfew on wife beating in the City of London bylaw. Wife beating wasn't allowed between 10 in the evening and 7 in the morning because it kept the noise kept the neighbours awake. This is incredible to think of. It's not because the woman was getting beaten up or violently assaulted, it was the noise kept the neighbours awake. In 1980s, rape in marriage wasn't a crime. And again, this is not a long time ago. And in 1984, Sir Kenneth Newman, Commissioner of the Metropolitan Police, described stray dogs and domestic violence rubbish work for police officers. We now think it's a core work for police officers. We've come a long way. And this is where we're looking at now. Again, the crime survey, all violence, stranger and acquaintance violence, people get into fights in pubs and stuff like that, and then domestic violence. And you see, there's been a substantial reduction in the last 20 years. Right the way across, it's a much less violent society, never particularly violent society, to be honest, not compared to others that you read about. But as I say, over the years, it's become a much less violent society, particularly domestic violence, and across the board with violence study. As I mentioned, the society is changing to deal with this rather than punishing the perpetrators. We've got the Domestic Crime and Violence Act, so that the act has been changed so that a woman can't actually say, oh, don't prosecute him, he still loves me. In fact, it's a police officer to decide whether to prosecute. And I was involved in a domestic violence case in the United Kingdom where a man had beaten up his pregnant wife, and it was her uncle who reported him to the police, and he went to jail for 5 years. But it was her uncle who reported him. He said, he's not doing that to my niece. And as I say, I was involved because I'd admitted the lady and documented her bruises and stuff like that. You with me? But as I say, it's changed a lot, very, very, very much more towards the protection of the woman rather than just getting away with a caution or what have you. These crimes are frequently now prosecuted. So Everett Knoop, he was the Surgeon General of the United States, and I'm going right back now to the first slides about how our predecessors looked at their problems in obstetrics, how our predecessors looked at their challenges and responded to them to reduce maternal mortality, to reduce perinatal mortality. Our response is maybe to a different set of problems. Everett Knoop says, violence is every day a public health issue for me and my successors in this century, as syphilis, TB and smallpox was for my predecessors in the last 2 centuries. He's outlined, and this man was the Surgeon General of the United States, and I can only just outline that really we as profession, as obstetricians, we in our profession need to respond to violence to pregnant women. Not only is it wrong, it's actually, there might be clear, defined obstetric benefits to actually dealing with it. So thank you very much for listening to me. And as I say, I'm very happy to answer any questions. Thank you.
Thank you very much, Dr. Stephen, for an elaborate presentation. This lecture was really an eye-opener for us because we hardly talk about domestic violence publicly to the patients, so we do not come across the real incidents of domestic violence or intimate partner violence. I did a small study where we also observed abortion, premature labor, preterm births, low birth weight, especially in victims of the violence. Mm-hmm. It's very difficult in India to extract the history from the patients, especially if somebody, most of the time, somebody from the family is listening. So it's very, very difficult. Alcohol intake actually is very important. And I've seen families where alcohol consumption increases the violence, irrespective of the female's status, whether pregnant or not. Poverty remains a very important factor, and economic dependence is very, very important in India. Thank you very much.
Yeah, I think that very, very important comments, Dr. Nisharani. Very, very important comments, because as I say, there is quite a lot of literature coming out from India, but it obviously India is a very, very big place and geographically very diverse as well. But as I say, it's a problem that we're all having to deal with bit by bit.
Now I invite Dr. Rakesh and Dr. Asha Bachi for the special comments.
Thank you very much, Mr. Stephenson, for such a lucid talk. And actually, it is an eye-opening talk. We always thought that domestic violence is only the problem of India, but then it is. From your statistics, it seems that it is a big problem in European countries also. And another thing was its impact on pregnant women. I think that is a very, very important thing because that is where something can be done. And I was surprised that you said that by proper counseling of the woman herself, things could improve. So I think that is where we all have to think about. And one good point was that having a look means whenever we check the woman, at least once we should really check her in alone rather having all her relatives there. And maybe that is the time she can talk about her problems, and we should initiate her to talk about it, and maybe that will help. So it has been a really, really very good session and learned a lot from it about the men's behavior, which is not open to corrective measures. So you can't do a lot there. I think we have to do more on woman herself, and I think society as such has to improve the education, the economic independence. That is what is important, and things are coming up. And nowadays, even movies are. Recently, there was one movie, Thappad. You might not be knowing, but there was a movie which was totally on this, that the man slapped the wife. He gave a slap to the wife, and that is it. So I think people are really understanding this, that woman has a right and she should not be beaten and she should not be treated like rule of thumb, as you have mentioned. So I think it's an excellent talk, and it makes you feel really human, that you think about that aspect. At the moment, we just think about giving obstetric care and doing those things, but I think this part is a very delicate part, and we have to be really human and empathetic, and we have to really deal with this aspect of woman as well. Thank you very much. Thanks a lot.
I'd be interested to hear, though, that when we talk about woman's perspective of it, the British woman we thought might be offended at being asked. They weren't. They felt supported, that somebody was actually interested in them. And another thing that we did in our hospital was in the female toilets. Obviously, there's no men going there. We had little credit cards, just little cards in the toilet with helpline numbers on them.
Good, yeah.
So in other words, if the woman wanted to just to pick one up, put it in her handbag, and then call the helpline number at a later date, then yes. If there was a man or a mother-in-law or what have you with her, nobody knew that she'd picked that card up because they were just sitting on in the female toilets only. With me, just to make sure that the woman could actually call and receive help. Because I think
it's very, very important. Yes.
Oh, thank you for your kind comments. So, because I say it is something that everywhere deals with.
Yes.
Everywhere deals with. It's not the east or the west or the north or the south. Everywhere.
Human beings are same, I think, everywhere.
They are. Yeah. Thank you for your kind comments. So.
Ashok Kumar, sir.
Yeah. Ask me, sir, as well.
Thank you very much, Dr. Stephen Lindo. It was a great talk, and you really highlighted that, yes, domestic violence or intimate partner violence is everywhere. I think it is a part of every society, yes, irrespective of the race or wherever you are living. And yes, everyone has to face. And as an obstetrician, beside tackling obstetric complication, we have to tackle medico-legal problem also, because these victims, they come to the emergency with external injury also.
Yes.
So law has to take its course also sometime. But in our place, most of the time, there is a mutual understanding, and law is not coming into the force. The third part, which is important when we talk of intimate violence, is the society role or the behavior modification of the couple or the family as a whole. I think that needs to be looked into, and needs a lot of awareness and education on this part. I think it has to start from the very early in the life, and then only these values, we say, in our Indian culture that the values and the custom and the habits which has to be developed in the younger minds before they come into adolescence or they come into the married life. I think from there these things has to develop, and really now people are becoming aware, and this problem is being brought into the light also and coming into focus by the doctor as well as by the couple also, or by the family also, or by the victim also. They're coming in also into the focus and coming out in the society to raise their voice. So I think slowly time will change, and especially in our Indian society where we have different values and custom, or the family society which is there. So I think slowly the time will change and we will see less of such type of incident.
I think that's very right, Dr. Ashok. I think that's it. And by having a meeting and talking about it and discussing it, we're sort of taking it out of the shadows. Yes. We're bringing it into the mainstream. We're talking about it. We're discussing it. You know what I mean? You know, next thing is that we found it very interesting to bring the midwives on board, from being very, very resistant at first to have anything to do with it. And then after that, they felt, oh, hang on, this is our job. We should be helping these women. We should be listening to
Dr. Stephen Lindo, the main problem in our society is that women are not coming up. And most of the time when we try to take history, I think majority, more than 50% of the time, we will not get any information about domestic violence.
Yes.
That is the main problem, because they try to hide it. Whatever you do, you take them into an isolated place, you talk to them in isolation, you develop first rapport with them, take into confidence, then also you talk to them. It is very difficult in the outpatient or in the hospital setting to take out this type of history from these patients. Even when you go to the community also, there also it is very difficult to extract this type of history from these victims basically. So this is the main problem in our society. The second, I have a query, one question regarding your Hull study. In your study, I saw one graph where the age of the, I think, victims were less than 15 years also. So what type of violence they were facing?
Sorry, what type of?
What type of violence, or what type of intimate violence or domestic violence they were facing? Were they they were married or unmarried, or what?
No, they would virtually all be young unmarried girls, schoolgirls who got pregnant. You with me? And ended up keeping them. There was quite one of the time that Uma Pandey and I were in Hull. Hull had one of the worst rates of teenage pregnancy of anywhere in Europe. And again, down to poor education, poor social circumstances, lack of parental support. And it wouldn't be uncommon to see 14 and 15-year-old girls pregnant. But I think in those cases, and this is what used to happen, then the father would hit her because she got pregnant. And then sometimes then even banish her from the house. So she ended up living with her grandparents or an auntie or something like that, because she was thrown out of the house for getting pregnant and bringing disgrace on the family.
Thank you very much.
Question, Mr. Lindo? Mr. Lindo, are you there? I remember when I was in Hull, there was a domestic, there was an injury from a ex-boyfriend of a woman. He stabbed her in back, and which went straight into her heart, and she died in accident and emergency with twin pregnancy.
Yes.
I vividly remember that case. I wasn't on call, but we were all kind of alert when she came.
It was only a couple of 100 yards from the hospital. He stabbed her in the street. No, absolutely, Uma. It's it's funny. The bad things seem to stay in your mind a lot better than the good things. But yes, you're right, and that was a big case. And I personally, in my time in Hull, looked after 2 murdered women. One was murdered antenatally, and one was murdered in the pure period, both by their partners.
Another thing I wanted to ask, Mr. Lindo, you said that it is less common in rich people. I was just wondering, how can it be less common when you said it is a human condition? So then I wonder, does that mean that the rich people do not tell it clearly or do not come out frankly like poor people? Because maybe rich people have 6 rooms in their houses, 6 bedrooms, so they can live in their 6 bedrooms apart. and they don't have to worry about what husband is doing or what the wife is doing, and they have ample money as they can spend on. I mean, could we study this rich guy problem? Domestic.
That's an interesting perspective there, Umar. I don't know, but what we do know that sometimes if you're rich and educated, you do have different avenues for anything. So you can go along and play rugby at the rugby club. You can go downhill skiing at 1,000 miles an hour. You can go on shark diving on holidays and stuff like that. If you do have, you follow me, a tendency towards irrational behaviour, for instance, there would be the outcomes. You know what I mean? That a rich person can actually take up that a poor person necessarily couldn't. Perhaps that's it. I don't know.
Okay. I just thought. Okay, thank you very much. It was very, very nice lecture. I'm sure I must have heard it, but I have all forgotten. Thank you. Thank you. Okay, now
Thank you, Lindo sir, for such an enlightening talk. Now. And I also like to thank you, our chairpersons, for chairing the session. Manjari Mata ma'am, Dr. Nisha Rani Agarwal ma'am, Dr. Shikha Sachan ma'am, and Dr. Mamta ma'am. And I also like to thank Dr. Ashok Kumar sir and Asha ma'am for their expert comment. Now we will proceed with the interesting session that is quiz on COVID-19 in pregnancy, which will be moderated by Dr. Divya Dwivedi. She is currently working as assistant professor in Heritage Medical Institution, Varanasi. She is former senior resident in IMS BHU. She has member of VOX. She presented papers in AICOG and UPCOG. She is actively participated and conducted quiz on research methodology in workshop organized by FOXY in association with VOX in December 2018 at BHU. Now, over to you, Dr. Divya.
Thank you, Dr. Vanita. A very good evening to respected dignitaries, seniors, colleagues, audience, and dear residents. And today's quiz on COVID-19 in pregnancy. We have two. I would like to share my screen. It might take some time, please.
Just go to the share screen, the green
yes,
button.
ma'am.
Open your Open the quiz.
I need to open my PowerPoint first and then.
Yes, that's what I'm
yes,
saying.
Okay.
Open the PowerPoint in the background.
Dr. Divya, can you just unshare it now? 1 second, I'll just guide you through it.
Okay, sure.
So first, once you press the share screen button, just select the first option that comes on top, which is screen.
Yes, I have selected that.
Okay, so now we will see what you are seeing. Right.
Is it visible?
Yes, it is now visible. So can you go back a slide, madam? Yes, perfect.
Thanks a lot, Mr. Sheshan. So the quiz is on this thing is disrupting me. Okay, fine. COVID-19 in pregnancy, and there are two teams. Team A is the coronavirus, and the team head is Prachi, followed by Samidha, Megha, Aksa, and Deepti. The team B, the COVID fighters. The team lead is Simran, and other members are Dr. Ankita, Shilpa, Ritambra, and Ujjwala. There are 20 questions in the quiz, and for each correct answer, 10 points will be awarded. For answering a past question, 5 points will be awarded, and there is no negative marking. So now I will proceed with the quiz.
May I request the teams to kindly unmute themselves, and after every question and the option, Dr. Divya, may I request you to kindly ask the respective team to answer so that we know that only they answer. Thank you.
So the first question goes to team A. coronavirus is? The options are A. Negative sense single-strand RNA virus. B. Positive sense single-stranded RNA virus. C. Double-stranded RNA virus. And D. DNA virus.
Madam, can you go back a slide? Yeah.
Positive sense single strand.
Dr. Divya, can you please click on that option?
B. Okay.
B.
That's the correct answer. So I would like to explain in short what does the positive sense and negative sense single-stranded RNA virus means. When we say it positive sense single-stranded RNA virus, we mean that the genome of that virus is directly acting as a messenger RNA, and proteins can be synthesized from that directly, that will help in the viral multiplication. While in case of negative sense single-stranded RNA virus, we have the virus needs to synthesize the sense strand from the negative sense strand, which is acting as its genome, and from that that positive sense strand, the messenger RNA will be formed. So the next question goes to team B.
Madam, please go back a slide. If you see, you have to click.
Okay, next question.
You have to click on the next question. Yeah.
So the next question is to team B. Which of the following is novel coronavirus? Options are A. SARS-CoV, B. SARS-CoV-2, C. MERS-CoV, and D.
Novel coronavirus B है ना? B. The option B.
Option B.
B.
B. So the answer is correct. And now next question goes to team A again. What does COVID-19 what does COVID-19 stands for? It is the same as novel coronavirus. Option A. Option B says that it is the infectious disease called by novel coronavirus. C. It is unrelated to novel coronavirus, and D is none of the above.
B.
Good. So the next question goes to team B. Are pregnant women more susceptible to COVID-19 or at higher risk for complications? Your options are option A. Pregnant women do not appear more likely to contract the infection than the general population, and there is currently no evidence that pregnant women are more likely to be severely unwell. Option B says that pregnant women appear more likely to contract the infection than the general population. C. Pregnant women do not appear more likely to contract the infection than the general population, but they may have a more severe clinical course compared with non-pregnant persons of similar age. And option D, none of the above. So team B.
A. Option A. C.
Option A. No, only one person should answer. Please.
C.
Final answer, please.
Final. A. So I'm logging it as A. Sorry.
Madam, just click on try again for the next team.
So the question is passed on to
C.
Good. The answer is C. The ICMR and the RCOG guidelines, they say that the pregnant women are not more likely to contract the COVID-19 infection in pregnancy, but because of the state of pregnancy in which the immune system is suppressed, they are more liable to develop severe viral infection, and this stands true for the COVID-19 too. So moving on to the next question, question 5. This question goes to team B. Team A, sorry. Team A. Which of the following comorbidity predispose a pregnant woman for the highest risk of acquiring complication if they get COVID-19 infection? Options are A. A woman with chronic renal disease, B. Heart disease, C. Diabetes, and D. Thyroid disorders.
B.
Please, one member, I have already asked that initially, please. Yes, B. I'm logging it B. So you are right, heart disease. Now the question goes to team B. As per the guidance from Government of India, direct and high risk contact is defined as those living in the same household, working together in close proximity. C, healthcare workers providing direct care. D, traveling together by any conveyance. E, all of the above. So answer please. Team B. Time has started.
All of the above. E.
Okay, fine, good. I'm locking this up. Yes, you are right. 10 marks for this. Now the question goes to team A. Does vertical transmission occur with novel coronavirus infection? Your options are option A. Emerging evidence now suggests that vertical transmission is possible, but there is, however, serious limitations to the available evidence. Option B, emerging evidence now suggests that vertical transmission is not possible. C, it is definitely transmitted to the newborns and leads to miscarriages. And D, both A and C. Your time starts now.
A. A.
Okay, fine. That is right. The next question to team B. Which of the following is true with respect to effect of COVID-19 infection? A, the virus is teratogenic. B, COVID-19 infection is currently an indication for medical termination. C, breastfeeding is strictly prohibited by an infected mother. D, there are currently no data suggesting an increased risk of miscarriage or early pregnancy loss in relation to COVID-19.
D. D.
Time has started. Time, team B.
D. Your option D.
Hello, am I audible?
Option D. D.
Your
Option D, ma'am. Option D.
Option D. Yes. Okay, fine. You are correct. Next question to team A. Which of the following is true with respect to medical history to be asked in view of COVID-19 infection in pregnancy? And options are detailed travel history, symptoms of COVID-19, history of exposure to people with symptoms of COVID-19 or with diagnosed COVID-19, immunocompromised, all of the above.
All of the above. E.
Next question to team B. Which of the following is false with respect to dues of an obstetric healthcare provider managing a pregnant woman with suspected or confirmed COVID-19? Options are, if a woman meets criteria for COVID-19 testing, pregnant women for sure, she should be tested. Option B, obstetric management can be delayed in order to test for the COVID-19. Option C, elective procedures like induction of labor for indications that are not strictly necessary and routine investigations should be reduced to minimum at discretion of the care provider. D, if ultrasound equipment is used, it should be decontaminated after use.
B.
D. Okay.
B. B.
No, please answer. Only one person should answer, and only one. In the group, don't answer. So what should I lock it as?
B.
B or D? B, sure. B. Okay. Good. Next question goes to team A. Which of the following is false with regards to antenatal care for pregnant patients in COVID scenario? The option is women should be advised to attend routine antenatal care tailored to the minimum at the discretion of the maternal care provider at 12, 20, 28 and 36 weeks of gestation unless they meet the current self-isolation criteria. B, for women who have antenatal appointments can be deferred until 7 days after the start of symptoms unless symptoms become severe. C, for women who are self-quarantined because someone in their household has possible symptoms of COVID-19, and appointments should be deferred for 14 days in such case. And D, referral to the antenatal ultrasound services for fetal growth surveillance is recommended after 7 days following the resolution of acute MS.
D.
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 B. Okay, B for Bombay.
Fourth option.
Fourth option. Okay. Yes, you are right. Next question to team A. Team B. How many levels of PPE are there? And options are 2, 3, 4, 5. 3 levels. Option
B.
Okay. Yes, you all are right. Next question to team A. Which of the following is present in level 1 PPE? Your options are disposable surgical cap, disposable surgical mask, work uniform, latex gloves, or disposable isolation clothing. B, disposable surgical mask, work uniform, disposable medical protective uniform, disposable latex gloves and goggles. C, disposable surgical cap, N95, work uniform, medical protective uniform, latex gloves, and full face respiratory protective devices. And D says disposable surgical cap, N95, work uniform, or medical protective uniform with latex gloves. Okay, that is right. So the next question to team B, level 3 PPE is required in all except intubation. Option is intubation, resuscitation of suspected or confirmed patient. B, in surgery procedures, delivery of suspected or confirmed patient. C, autopsy of suspected or confirmed patient. And D, imaging examination of suspected or confirmed patient.
D.
Please say 1, 2, 3, 4 this time.
4.
Yes, you are right. Now the next question to team A. All are true with respect to care in labor in a suspected or confirmed COVID positive pregnant woman except A. Women with mild COVID symptoms can be encouraged to remain at home in early labor, consistent with routine. Standard early maternal observations and assessment should be performed with the addition of early oxygen saturation with the aim for saturation above 94%. C, water births are recommended. D, women with symptomatic confirmed or suspected COVID-19 should be offered continuous electronic fetal monitoring during labor and vaginal birth. So
C.
the answer, please.
C.
1, 2, 3, 4. I'm not able to appreciate you all now. Please. Please express in the terms of 1, 2, 3, 4.
3.
3. Okay. That is right. The next question goes to team B. How can prenatal care be modified to decrease risk of contracting COVID-19? A, number of prenatal visits should be the same as routinely practiced earlier. B, women should continue to be encouraged to take folic acid and vitamin D supplements as per standard recommendation. C, obstetric ultrasound examinations should be frequently offered in order to follow the fetal growth. And D, even if a woman has previously tested negative for COVID-19 and presents again with the symptoms, she should not be suspected to be COVID-19 affected.
B.
Yes, fine, good. What happened to this? Answer to this question is of course B. Rest all the answers are wrong because prenatal visits have to be cut down and obstetric ultrasounds are only advised at the first antenatal visit and anomaly scan to that at around 32 weeks and later on at term pregnancy.
Madam,
some
just
technical
go to
problem.
just go to the next slide, madam. The next, yeah.
Now the question goes to team A. Dash requires that all workers be provided with personal protective equipment. A. NIH, B. CDC, C. OSHA, and D. UNICEF. So you don't have time more than 30 seconds. Please take that in mind, and your time is about to. Mr. Session, please keep a watch on time. And I think A. Okay. So that was wrong. And the question again will be transferred to, in that case, to team
D.
D. UNICEF.
B. 2. CDC.
That too stands wrong. The correct answer is Occupational Safety and Health Agency that looks into these matters. In India, it is known by the National Occupational Safety Health Profile. So the next question goes to group B. Which of the following is the correct sequence of donning? Option A, hand hygiene, inner gloves, gown, shoe cover, N95 mask, hood of the gown, followed by face shield or eye goggles, then the outer gloves. B, hand hygiene, followed by shoe cover, gown, N95, face shield, hood of the gown, outer gloves and inner gloves. C, hand hygiene, N95, outer gloves, gown, face shield, inner gloves followed by the hood of the gown, shoe cover. And finally D, hand hygiene followed by the inner gloves, followed by gown, N95 mask, face shield, outer gloves, shoe cover. So team B.
10 seconds to go. 5, 4, 3, 2, 1.
A.
Right. You got it right. So the next question goes to team A. Which of the following is the correct sequence of doffing? That was donning and this is doffing. A, shoe cover should be worn first, followed by outer gloves, followed by face shield, gown, inner gloves, hand hygiene, N95 mask, hand hygiene. B option, shoe cover followed by outer gloves, gown, face shield, inner gloves, hand hygiene should be practiced, then N95 mask and hand hygiene. Again, C says shoe cover, gown, outer gloves, face shields, goggles or inner gloves, then N95 and hand hygiene, and D, N95 mask followed by shoe cover, outer gloves, gown, inner gloves and hand hygiene in that order.
A.
Okay, fine. That is the right order, and this order has been developed from the AIMS New Delhi guidelines of how to don and doff a personal protective equipment. So the next question goes to team B. Following practices are useful for the prevention of corona infection except, it's very easy, A, hand washing, B, taking over-the-counter drugs, C, social distancing, and D, cough etiquette.
D.
Yes. With that, I would like to end this quiz, and I would request Dr. Vanita to please calculate the marks of each team and declare the winner.
Yeah. I calculated.
Yes.
There are
quiz were
both
very good. Very good quiz. Please preserve the questions.
Thank you, ma'am. Thank you so much.
Very nicely prepared.
Thank you,
Both the
Mata
team,
ma'am.
And nicely conducted also.
Who is the winner?
yes, ma'am. Both the teams
Thank you
had
so much,
answered
ma'am.
one question wrong. So both the teams answered one question wrong only. But team A answered one passed on question. So team A lead with 5 marks. That is, they are having 95 marks, and team B is having 90 marks.
Oh,
So very close.
Close
Very close.
defeat.
so team A
Close
is
win.
the winner, isn't it, Vanita?
Yes, ma'am.
Team A is the winner.
Team A is the
A,
winner.
Corona Warriors are the winner.
Corona Warriors.
Corona Warriors, congratulations. Very well.
But they all should get the prize because the competition was very, there was a narrow margin of victory.
हाँ तो एक विनर है तो एक रनर है तो they will get prize, ma'am. Not
हाँ.
now. Online
हाँ.
later.
Anytime you can give them in the department, but they should also get.
May I take this opportunity to request Dr. Ashok sir to congratulate my residents, both of them. They did really well. Please, sir. Please, sir.
Yes. First of all, I think Dr. Divya has done a wonderful job.
Wonderful.
Thank you, sir.
Has done a lot of exercise on COVID-19 and really updated all of us or refreshen our memory, like revised our chapter on COVID-19, right? And I think all the residents have done very beautifully. All the questions were answered basically. Nothing was left without any answer. And I think all are winners. They know very much, and because they are all practicing everything nowadays and managing all the COVID-19 patients. So that is why they are up to date and they have done well. So best wishes for your future, for your exams. Thank you very much. Thank you, Dr. Uma, for giving me this opportunity and for your kind invitation. Thank you.
Thank you, sir.
Thank you, sir, for your kind words and appreciation. They mean a lot to us.
Congratulations, I think, to both the teams, the winner and the runner. Congratulations.
Are you still there? Mata ma'am,
Yes.
congratulate the Corona Warriors and Corona Front.
Congratulations to the A and B team both. I find them equally good. And there is a narrow margin. There is always first and second, but doesn't mean the second are bad. They are all good. And they should all get the prize. The quiz was good. The question selection was very good. Divya did it very well. The
Thank you
students
so much,
did it
ma'am.
very well. Vanita's job was also excellent.
I also congratulate both the teams.
Okay, ma'am.
Thank you, ma'am.
And Mr. Lindo, would you like to say anything? Because when I was thinking about this MCQ, I had asked you, if you remember. What would you like to say about our residents? Anything? We can't hear you. You have to unmute. We can't hear you.
I think that the residents are a fair bit sharper than I am. I'm glad I didn't have to answer those.
Okay, so it was very, very nice. Divya, I must congratulate you, millions of tons, and you have done so well. And it was my first MCQ online on webinar. I was too scared how it will happen, how we will ask a question, how they will answer this, how this will happen. Thank God, Divya, you worked out really well. So I want to thank Divya very much. I also want to thank my speakers, Mr. Shivan Lindo and also Dr. Ritu Khanna, both of them. I want to thank Dr. Ashok Kumar, who has been with us for so long. I really appreciate that. The Dr. Asha Bakshi has to go somewhere and therefore she left. Also want to thank Madam Mata, Madam Nisha, Dr. Mamta, Shikha Sachan. I can see Dr. Shuchi Jan there as well, so I would congratulate her as well. I can see my all residents. I have taken lots of pictures of you. I'll post it later when I get a moment. And then I would like to thank a lot Sheshanji. Sheshanji made it possible for us to do this MCQ. We had no idea. So Sheshanji, thank you a lot. Thanks a ton. And
Thank you, madam. Thank you very much.
Thanks Bharat Serum as well. Thanks, Vanita. Thanks, everybody. Thanks, the audience. And again, I would say I would thank that person I have forgotten the most. So please forgive me if I have forgotten.
Mamta and Chikha.
No, I didn't miss them, ma'am. Please don't remind me.
Sorry.
I mentioned them. और किसी का फोटो देखे तो बोल दे, बाकी तुम्हारे बच्चे लोग हैं, इन लोग को तो पता ही। अनुजा जी हैं, I thank her as well, and the support team of Bharat Serum. It was wonderful experience. I really enjoyed today's webinar. Thank you.
Thank you.
Manita's job was also good.
It was
Back up,
very
Manita.
Yeah, she did.
Thank you so much, and Dr. Sweta.
We had some questions.
Ritu, very nice presentation.
Thank you.
Sir Lindo, very nice
We had
presentation.
some questions for the
Anita and Devya also. Congratulations.
Thank you.
ma'am. We had some questions.
Okay.
I want to share.
They are for me or for Dr.
One
Sweta?
second, ma'am. 1 second, ma'am. I want to share the screen. Ma'am, there are few questions on RH isoimmunization. First, in RH negative pregnancy, there is on and off antepartum hemorrhage. How many times she required anti-D? This is a question from audience, ma'am.
Okay. So now if she has had an antepartum hemorrhage, then I think before we give an NTD, we really need to calculate the fetal-maternal hemorrhage that has occurred and accordingly give her the anti-D. And then we can repeat it at least minimum of 3 weekly interval. And we have to see again to how much is the bleed, how much is the titer if we are doing anything. And then 3 weekly we could repeat it.
Okay, ma'am. Next question, ma'am. What should be the mode of delivery if RH isoimmunized pregnancy to be terminated at 34 weeks?
If it's severely affected neonate, then she need to be delivered by cesarean. Otherwise, she could be delivered vaginally if mild affection.
Okay. And third question, how will we monitor fetus for anemia once we have given intrauterine transfusion to fetus less than 34 weeks in isoimmunized pregnancy? And how many transfusions are recommended in such cases?
So what we do is we do the ultrasound, we do the middle cerebral artery, and we do the peak systolic volume, and that's why velocity, and that's how we calculated that she is severely affected and we're taking her for an intrauterine transfusion. Subsequently also, you could monitor her by the middle cerebral artery PSVs, because you will find that they will go below the 1.5 MOMs. So that will be monitoring. You have to see it after a week again, and then subsequently, and your transfusions depend upon the hematocrit level that you have. So when the hematocrit level, what we want to achieve is 75 to 85% of the hematocrit that we need. So once we achieve that, then we can limit, but we cannot go on and on. We have to just see that if she suppose reach 34 weeks or something, 35, we give her for the lung maturity and try to deliver her.
And last question, ma'am. How to proceed with women with RH isoimmunized pregnancy with high titers, high anti titers at less than 20 weeks?
So a little dilemma here, high titers, what it means, because in a different labs will be having a different stature. Suppose that the method that they're doing, we have to see it's a tube or a gel method or what it is, because the gel method gives a 4 times higher rate. So suppose she has 1:16 or 1:32. So it is not one high titer. You have to see the sequence, the rising titer, which is much
Serial
risk has to be there. And if it were less than 20 weeks, actually it is, if she just had one titer is high and you are going on with her, with the monitorings and she's doing fine, then you can continue. But once the rising titer comes and she's less than 20 weeks, I think we taking her to around 32, 34 weeks will be difficult. So prognosticate her and then go on managing her.
Okay. Thank you, ma'am. Thank you, ma'am. At the end of session, I would like to thank you, today's guest of honor, Ashok Kumar sir and Asha Bakshi ma'am, for their precious time. I like to thank you, our speakers for today, Dr. Ritu Khanna ma'am and Mr. Lindo sir, for their precise talk and enlightening us on the such beautiful topics. I would also like to thank our chairpersons for today's session, Dr. Manjari Mata ma'am, Dr. Nisha Rani Agarwal ma'am, Dr. Mamta ma'am and Dr. Shikha Sachan ma'am. I would like to thank you, Uma Pandey ma'am, for organizing this scientific test. Thank you so much, ma'am, and thank you for giving me opportunity for moderating this session. I would also like to thank you, Dr. Divya, for organizing such a good quiz, and I also like to thank you, our residents, for preparing and participating in the quiz. Thank you so much.
Thank you, Uma, once again, and Divya, and also Vanita. Wonderful moderation, a wonderful session we had.
Thank you.
Thank you so much, ma'am. Thank you, Mata ma'am, for your loving and encouraging words. Uma ma'am, I'm thankful to you for giving me this opportunity. That's why this quiz could be a success. Ritu ma'am, thank you so much, ma'am. Thank you, sir, Stephen sir, for delivering such a wonderful lecture and enlightening us all regarding the role of domestic violence.
Correct.
Thank you, Mr. Session.
It's called Stephen.
Thank you very much. I've really enjoyed the session. Really nice. Well done. Thank you very much, everybody.